Thank you for joining us. This is, as you probably know, the second time that we've all convened together in order to discuss an interesting case that we shared between our two institutions. And this time, of course, we are also invited, and we're happy to have the physicians and staff from Genesis East joining us as well. And so we're going to be discussing a patient that was referred to us in shock, and we'll be discussing sort of the relevant points and things to consider when resuscitating a child in shock in the era of coronavirus. Here's just briefly, we'll go over the quick agenda. You can see we have just a couple minutes for the welcome and introduction, at which case Dr. Curl and then Dr. Haskell, our Pediatric Critical Care Division Director, will be presenting the salient points in this patient's hospital course, both pre-hospital, emergency room, and then at the UI Children's Hospital. After that, we're going to have just a 30-minute talk real quick on recognition and treatment of pediatric shock, after which we'll then have an overview by one of our rheumatologists, Dr. Hong, about MISC and have some of the latest updates on what's going on in the world of MISC. We'll have a short break. During the interactive virtual simulation case, we're going to try and divide into two groups, and we'll try to keep you all together based on your hospital affiliation so that you can work with the team that you're usually accustomed to working with. So if you did not pre-register, please add your hospital affiliation to the name in your screen so that the folks helping us in the background and also Dr. Balakai and Dr. Lungrath can assign you to the appropriate group. After the virtual case, Dr. Khan, a pediatric cardiologist and specialist in pediatric heart failure, will discuss myocarditis, and then we will close. And of course, we're happy to take questions. If you would just add them to the chat box throughout the case, then we can address them at the end. And we'll try to move quickly through each of these things and stay on time so that everyone has the time they need. I'm just going to check. I see a couple things in the chat box already. Okay, it's from Dr. Sifra. So just a quick reminder that we're here to learn and to share our experiences with patients we have shared. And so we welcome collegial interactions, questions, and conversation. And then we also ask that you please do not disseminate any information about the case outside of this forum. We have de-identified all of the personal health information, but of course, this is a private meeting and we don't want to discuss this further outside of this forum. If you would, please mute your microphone so that the speakers are not interrupted. And then, as I mentioned, there will be time for Q&A at the end of each lecture. The session is being recorded, as you probably got an alert for, so that we can make it available to you again at a later date. These are our core organizers. You can see a few names on your left, our group from UIHC, and then we have special thanks to Dr. Curl and Emily McDowell from Trinity, and then Destiny De Lamos from Genesis East, who has helped us to coordinate this as well. And so with that, I will stop sharing. Tina, do you want to introduce Dr. Curl?
Absolutely. Thank you everyone for being here. We are so excited for this session and excited to share all the things that we can learn about this case. So I'm going to hand it over to Nate Curl from Trinity Unity Point to share this common case. Go ahead and share your screen, Nate.
Let's see. Now it won't let me share my screen. Why won't it?
No worries. If you can't, I will. We do have your slides.
Yeah, just go and pull them. Yeah.
Let's pull it up.
Yeah.
Sorry, it is loading right now.
That's fine.
Sorry, wrong one. Hang on.
Yeah, it says.
Share because you're not a host. Hang on. Sorry. Here we go.
We got it. There we are.
Are you seeing the full screen?
Yeah.
All right. Let me know when I'll advance your slides.
Yeah. So yeah, thank you, Dr. Sifra and Dr. Tigas for having me this morning to just go over this case briefly. As Dr. Tigas did mention, this is all confidential. This is based on a true case, so it should not leave this forum. We can go ahead to the next slide. This is the pre-hospital course. I went through the run sheet and kind of reviewed that. So 7:43 in the morning, EMS is sent out to a private residence for the call-in was for an unconscious, fainting or near fainting adolescent male. They were there within 5 minutes, which was great scene time. And they found the patient lying supine on the ground next to the bed with rapid and shallow breathing. He did have a pulse present when they arrived. He was confused, but was able to speak at that time. Family said he had possibly had a seizure for about 8 minutes and then fell just before they called 911. And they said he's otherwise a healthy adolescent male and no significant past medical history. The pre-hospital vital signs you can see there: heart rate's 128, respiratory 28, BP 85/31, and he's 90% SpO2 on room air. Because of the trauma, possible trauma, they did place a cervical collar and they put him into a stair chair. It was an upstairs, I think a 3rd floor apartment that the patient was in. So they put him into the stair chair to try and get him down to the ambulance. And unfortunately, while sitting in the chair, he went apneic. So they got him out of that chair and onto one of those big orange tarps that you've probably all seen in the ED that they use for transporting patients. He did have a pulse the entire time. And at that point, they did begin to assist the ventilations with bag valve mask and the standard 15 liter per minute oxygen. They did notice something that could have been a seizure at that point. So they did give 5 milligrams of midazolam intranasally, carried him down to the cot, loaded him onto the ambulance and tried to suction the airway, but he was clenching his jaw. So then they placed a nasopharyngeal airway without any difficulty. And that's a trouble. You know, anytime somebody's letting a big piece of plastic like that just hang out in their nose is a little bit worrisome for me. They did try an IV, they couldn't get it, so they got an IO and gave a 400 ml NS bolus. They got capnography, initiated pre-hospital, and then got a blood glucose of 135. They did try naloxone through the IO with no change, just on the off chance that this was an opiate overdose. There's really no downside to trying naloxone in these situations because, yeah, if it's not, it won't do anything. Then they were assisting his ventilations and transported to the hospital. So arrival time is about 20 or so minutes later. They came to the ED and they went to our big resuscitation bay. And we can go ahead to the next slide. So the ED physician was there immediately. Obviously, they had pre-hospital notification that a very sick patient was coming, so everybody was pretty well ready for them. They confirmed the EMS history, rechecked the blood glucose, it was fine, 82, and later got some history from the family that 1 week prior he had been sick with abdominal pain, nausea, vomiting. Symptoms got briefly better, but then returned, and he hadn't really been eating or drinking ever since. Increasingly generally weak for the past few days and did not want to go to the doctor. And then there are vitals there when he gets to the ED. So 1055 for rectal temp, heart rate 131. Blood pressure is a little bit better with that fluid, so 109/48. And then he's being ventilated with the bag valve mask, obviously. So, and then our weight there, 109 kilos. So thankfully we can do adult doses for most all the medications in this instance because of the weight. Don't have to do any or don't have to do a whole lot of mg per kg dosing in this instance. So GCS3 noted maybe a little bit of a decline in the mental status by the time he arrived, and then some repetitive shaking motions in upper extremities. They got a bolus of saline going and then went right to intubation with rocuronium and etomidate. No trouble there. 7.0 ET tube, 24 centimeters, confirmed with the chest x-ray. 10 minutes after that, there was cardiac arrest. So they did initiate CPR for 2 minutes, 1 dose of epinephrine with return of spontaneous circulation. And then they started to address the hyperthermia with ice packs, cooled IV fluid, and then also started on fentanyl drip and norepinephrine drip. Started broad spectrum labs were drawn in here somewhere as well, I'm sure, because then broad spectrum antibiotic coverage was started for possible sepsis. So they used vancomycin, meropenem, and Tylenol or acetaminophen suppository for the fever. We get some labs back. Lactic is 11.1, obviously points to poor tissue perfusion of some sort and shock, which we'll go into all the details of shock here in a little bit, but clearly very sick child. And so made contact with the university ED immediately and ordered another bolus of saline at that point. Another cardiac arrest here at 9 o'clock, 9:06. So same idea, 2 more minutes of CPR, responded to epi. At this point, they did load him up with levetiracetam for the possible seizure-like activity. And then also during the code, sodium bicarbonate and mag sulfate were also given. And let's see, just a few minutes later, he was accepted to the PICU at the university, and the intensivist did recommend starting an epinephrine drip. A few minutes later, our general surgeon was available for a central line placement. So he did a femoral central line in the right femoral vein without any trouble. And then our glucose is, the patient's glucose is starting to dip a little bit into the 60s. So we got some D50. We got another bolus of saline going on, and then the air transportation crew did arrive. We added on vasopressin at that point. We did give a dose of solumedrol, and the physician did let the patient's family know that he was very critically ill. And we got a 4th bolus of saline going. So 4 liters total of normal saline bolus, 2 different pressors, or 2 or 3. I don't know if they all continued or not, but anyway, 2 or 3 different pressors going on, broad spectrum antibiotic coverage, central line placement, and airway. So that was kind of a condensed history of what happened in the ED. Labs, we did get, the UA did show many bacteria, 31 to 50 white cells. Troponin I was up at 6. Thyroid was fine, white count of 32. You can see in the chemistry, obviously, bicarb of 14, BUN 86, and creatinine of 8.0. So acute kidney injury and some metabolic acidosis going on. Liver tests, AST and ALT are both up a little bit too. We did do some tox testing. That was all okay. So Tylenol, salicylate, ethanol, urine drugs were all okay. And then CK for the patient was in the 22,000s. So ABG following intubation, pH of 7.12, PCO2 and PO2 were okay. And then the bicarbonate there at 12.4. So that goes with the metabolic acidosis. We did get the call 11 hours after, so after the patient had already been transferred, that one of the 2 blood cultures was popping positive for E. coli at that point, and it was susceptible to all the antibiotics that we tested in our department, so it should be covered by what we initiated in the ED. And then just last, I have some imaging results, nothing really to write home about here. Chest x-ray, maybe an enlarged heart. Head and C-spine were good, nothing acute there. Abdominal and pelvis CT, I think that was probably ordered based on just the GI symptoms that the father had related, and maybe an early partial small bowel obstruction, and then definitely some evidence of hypovolemia, which goes with, his other clinical symptoms that we saw too. So that's what we had from our end, and then off went the helicopter, and we'll let the university pick it up from there.
Yeah, thank you, Nate, for that overview. Next, I'd like to introduce Dr. Sarah Haskell. As I mentioned earlier, she's one of our colleagues and also was recently named our new division director. So we're happy to have her joining us today. She cared for this patient during his PICU course. Sarah, it's my impression that you've been made a co-host, so you should be able to share your slides. And if not, we'll have a backup plan. So please go ahead whenever you're ready.
Can everyone see that okay?
Yep.
All right. Thank you so much for the opportunity to present the PICU course today. I'm very excited to participate in this collaborative and these great cases that we share. With that, I will talk about his PICU course, particularly focusing on that first day. Sorry. So upon arrival, the patient was still febrile. Tmax was 39.4. Heart rate was 139. Respiratory rate was 18. Blood pressure was stabilized with all of the resuscitation at the ER, and SATs were appropriate at 98%. He did arrive on 3 pressors, at epi at 0.06 mics per kilo per minute. Norepi was at 0.4 mics per kilo per minute. And vasopressin was at 0.04 milliunits per kilo per minute. He was intubated. As mentioned, he was adult size, so appropriate settings for his age. And the transport team did also express concern for seizure-like activity. The physical exam on arrival, he was clearly intubated and sedated. He was tachycardic. A wheeze was noted with inspiration. At that time, his abdomen was not distended and overall soft. His extremities were cool to the touch with a thready pulse. His initial labs here were notable for the CO2 of 17. His BUN was 74 and creatinine was 6.3. Mildly elevated glucose, amylase and lipase as noted. AST was 591 and ionized calcium was 3.5. Albumin was 3.1. He did have an elevated white count at 30.6. Hemoglobin, hematocrit, and platelets were relatively stable, and the CRP was noted to be 42.6, highly elevated on our scale. His CK was uptrending at 33,000, and our pro-BNP was 45,000. His troponin was 501, and his lactate had decreased significantly from the 11 at the ER down to 1.8 upon arrival. His first blood gas here was a venous blood gas. It was 713, 56, 46, and -11. And it was noted very quickly that he was COVID positive. His initial course here, he did receive an additional 3 liters of fluid. His vasoactives were titrated and they were able to make some headway in weaning those. He did receive several boluses of calcium chloride just for that initial value of 3.5 and some intermittent hypotension, as well as some sodium bicarbonate. They did place an arterial line, continued the fentanyl for sedation, and added cisatracarium for paralysis. And he did get an echo, EKG, and the MISC labs shortly after arrival. Excuse me. Cardiology was consulted and nephrology because of the COVID positivity and presentation, as well as the E. coli positive culture. ID was involved and rheumatology. And then with the outside CT raising the concern of small bowel obstruction, ped surgery was also consulted. Parents did confirm that the most notable symptom was the GI discomfort with nausea, vomiting, diarrhea, diarrhea and abdominal pain. The echo on admission did demonstrate that there was decreased left ventricular systolic function. Also noted prominent coronary arteries. So the proximal LAD was 5.5 millimeters, the proximal RCA was 4.9 millimeters, and the left MCA was 5 millimeters. So that was the very first echo on admission. And the EKG did demonstrate signs of ST segment depression as well as elevation concerning for proximal occlusion of the left LAD, consistent with ischemia and infarction. Unfortunately, about 6 hours after admission, the patient's rhythm changed, which you can see here from the little snippet of the vitals. There was no pulse noted and CPR was initiated. This would be the third code event in a 24-hour period. It was again a brief code. The patient did receive 2 epi boluses and had ongoing CPR, did achieve ROS within 5 minutes. Because of the third code event and the LV dysfunction noted on echo, we did decide to go ahead and place the patient on VA ECMO, given the risk of recurrent cardiac arrest and to allow the heart function to recover. From there, the ECMO course was 8 days, which is in our mind a little prolonged for VA ECMO, but the patient definitely had recurrent arrhythmias, particularly in those first 3 days, and was incredibly sensitive to catecholamines. Once he was decannulated, he was quickly extubated, and so his intubation was just for 10 days. He did continue on the antibiotics for the E. coli and treated. He also did get the MISC treatment. So he did receive IVIG on days 1 to 3, and then Solumedrol, large dose for 3 days, and then followed by 60 milligrams BID for 18 total days, and then a steroid taper to go over 30 additional days. Because of his severity illness and his labs, he was also given anakinra for 18 total days. His anticoagulation initially was per ECMO and our protocol. He was on heparin for those 10 days, so 2 additional days post decannulation, and then was started on aspirin given the dilated coronary arteries on day 2, and was started on enoxaparin on day 11. He was discharged on day 25. Remarkable at the time of discharge was he was afebrile, had stable dynamics, was completely neuro intact. He was on EEG during the hospitalization, but was never noted to have seizures. He was on room air, eating a general diet, and got discharged on a steroid taper, continued aspirin, Lovenox, and famotidine. His echo on day 21 continued to show the dilated proximal RCA and left MCA, dyskinetic LV wall motion, but the function had returned. And so a normal shortening fraction and ejection fraction. And then I have at the bottom his labs at the time of discharge. And you can see what they were currently. And then in parentheses, we see the peak values during his hospital course. With that, I'd be happy to answer any questions, but I'm excited to discuss this very interesting and complex case.
Awesome. Thank you so much, Sarah and Nate. Are there any questions for both Dr. Haskell and Dr. Curl regarding the patient's course? I think it's remarkable that he survived neurologically intact at discharge. That's incredible. If you also would prefer, you can put in your questions in the chat box.
Hi, this is Dan Kinker from Genesis. I was kind of wondering what kind of dysrhythmias was the child going through when during those episodes and cardiac arrest?
The initial one, his heart rate was in the 160s, and I believe they thought it was atrial in nature with that one. While on ECMO, his flows and his blood pressure continually kind of kept cutting out for brief periods. And so the ones while on ECMO were thought to be a little partially due to just the catecholamines, and that he was so sensitive because they were often triggered by increasing either the epi or norepi. But the initial one, when he came in, they did think was atrial upon initial inspection. And I can look more, the cardiology, Dr. Khan will talk as well, but we did have some trouble teasing out the rhythms, particularly while on ECMO.
And then Sarah, Jeffrey had put in the chat, were antiarrhythmics recommended or used upon arrival at UIHC?
They were not when they were discussed, and his heart function was so low. They were worried about some of the antiarrhythmics in that setting. Really, once we kind of made the transition to lowering our epi and norepi, our catecholamines, and using vasopressin, they definitely did decrease. But while on ECMO, we were fully supported, and so we did not start any antiarrhythmics. And just felt like the treatment with the IVIG for the MISC, once we kind of got through that as well, we noticed an improvement. Great questions.
Certainly not a straightforward case. Are there any other questions before we move on to the next session? All right, at any time as well, if you have questions, please just put them in the chat and we can answer them during the next breaks after each session. Just wanted to remind everybody as well, thank you to those who have already put in your institution with your name on the Zoom screen. For the rest, if you can please do that so that we can make sure that you go to the correct breakout room when we do our virtual simulations. That would be great. So for our next session, I'm going to hand it off to Cody. So Dr. Tigis is one of our pediatric intensivists, and is also our outreach liaison, and is also leading the Iowa Pediatric Emergency and Critical Care Consortium. So he will be presenting on the general recognition and treatment of pediatric shock. So Cody, take it away.
Okay, thank you, Tina. One other thing, just real quickly before I get started, for those of you who joined us after 8 o'clock or so, we do have a pre-session survey that we're asking you to complete. And so I'm just going to paste the link again in the chat box. And so it's 10 questions, mostly demographic stuff. If you wouldn't mind filling that out for us, we would really appreciate that. So as Dr. Siffer mentioned, I'm just going to go through the recognition and treatment of pediatric shock. Our objectives for this talk, one is, things oftentimes will start with the definition. And so I think in order to really understand something at the bedside, at least for me anyways, it's helpful to understand the definition. We learn from textbooks, but then the goal, of course, is to apply that. And so Learning physiology and the definition of the illnesses we treat has helped me to understand them and apply them to my practice. And so I would like to sort of discuss the definition of shock, but in a way that helps us to think about it at the bedside. And part of that, as I mentioned, is the physiology. And so we'll review the physiology of oxygen delivery. And then because, again, at least for me, it helps me to understand how the body then responds when it senses that oxygen delivery or oxygen utilization is inadequate. And then finally, we want to apply that to patient care. And so towards the end, we will highlight some of the most relevant points from the guidelines put out by the Surviving Sepsis campaign as they relate to pediatric shock. So as I mentioned, we want to start with sort of the basic definition. And so I have here the question, what is shock? And as you all probably know, shock is impaired or inadequate oxygen and or substrate delivery to the organs in order to meet the metabolic needs. And this can happen in a couple of ways. One, it can be either an absolute decrease in oxygen delivery, or it can be a relative decrease in oxygen delivery. So if metabolic demand goes up, but the cardiovascular system is unable to respond, then that would be a relative decrease. So now because of the increased metabolic activity, the delivery of substrate is now inadequate. There can be ineffective tissue perfusion. So you may have good cardiac output, but it's not perfusing the tissues. And finally, the end cells, the end organs, might be in a condition where they aren't able to use the delivered oxygen effectively. And so when either of these scenarios occurs, cellular metabolism becomes anaerobic, produces lactic acid, and eventually the cell membrane ion pumps are disrupted and the cell ruptures and dies. And that, of course, leads to tissue, organ, and host death. So there are many different kinds of shock depending on how you break it down, but these are usually the four main categories. The first is obstructive. And these are in no particular order. I say the first, but I don't mean that it's like the first or most important by any stretch of the imagination. But obstructive shock is characterized by an extracardiac lesion that results in decreased LV output. And so and this can be further categorized into issues with the pulmonary vasculature. So perhaps a pulmonary embolism or something that provides this obstruction to blood flow, or this can be a mechanical issue like tamponade. A second form is hypovolemic. This is probably the most, one of the most, if not the most common cause of shock worldwide. And usually this is because of patients in developing countries, particularly in pediatrics, who may develop a GI illness and have fluid losses through diarrhea or vomiting and don't have access to medical care to sort of replete their intravascular volume. And hypovolemic shock is initially characterized by decreased intravascular volume, as you would expect, and increased systemic vascular resistance. But then as these ongoing losses continue and the intravascular volume is further depleted, cardiac output then also progressively decreases and the patient becomes hypotensive. This can be sort of thought of in two other ways as well. One is hemorrhagic. I'm sure that those of you working in the emergency department are familiar with traumas and patients in hemorrhagic shock. As I mentioned in pediatrics, this is often falls more so into the non-hemorrhagic category with like GI losses or renal fluid losses, something like that. A third major category of shock is cardiogenic. And so this is characterized by an intracardiac lesion. And so that sort of differentiates it from the obstructive version of shock. And so this is an intracardiac lesion, as I mentioned, that results in decreased cardiac output and systemic perfusion. So examples of this would include cardiomyopathies or myocarditis. That this is probably relevant to our case. This can be arrhythmias, which is also relevant to our case, or this can also fall under a mechanical process as well. For example, a valve regurgitation, like an aortic insufficiency, something like that, where whatever blood is being pumped forward then flows backwards and compromises tissue perfusion. And finally, the fourth major category is distributive. And so distributive shock is characterized by a peripheral vasodilation that impacts tissue perfusion. SIRS and sepsis, as you can see, is one of the subcategories of distributive shock. Anaphylaxis is another, and thirdly, neurogenic. If you have a cervical spine injury or something similar to that, those can all result in a distributive shock picture. I put a little asterisk next to sepsis because we often think of sepsis as being as contributing to shock in multiple different ways, and so it's not just a distributive picture per se. It can also have components of a cardiogenic shock, for example. If there's a metabolic acidosis, then perhaps the inotropic activity of the heart isn't sufficient to generate enough stroke volume in order to support the cardiac output. And so, or oftentimes, especially in pediatrics, a patient in septic shock may have had diarrhea or decreased oral intake. And there's also a hypovolemic component to their shock as well. And so sepsis can really sort of consist of multiple different of these categories. So when we describe patients in shock to each other, we oftentimes will use the term uncompensated shock. And this helps us to really understand the severity of illness and where the patient is in the course of their illness. It also helps us to understand when the shock was recognized. And so uncompensated shock, which you are all familiar with, is the patient who has already deteriorated. They're hypotensive, they have thready pulses, the kidneys are not being perfused, and their urine output is already down. If you get labs, you can see that the metabolic acidosis is increasing, and just by feeling their fingers and toes, you can tell that their extremities are cold. They do not have good peripheral perfusion. Now, we contrast this with compensated shock. And so these are patients who are tachycardic and may have bounding pulses, but still have a relatively normal, maybe the low end of normal blood pressure, who are still producing a little bit of urine and have perhaps a mild metabolic acidosis. So say a lactate of 3 or 4 instead of a lactate of 10 or 11. And when we talk about shock with our residents, we really harp on the differentiation between these two conditions because we want our residents to recognize patients who are in compensated shock on the floor and get a critical care consult or transfer the patient to us before they decompensate on the floor. And so, but it can also be really tricky. So how many pediatric patients are there who are tachycardic, and there are a number of reasons. They could just be hungry. And so it can be tricky, but we always ask our patients, or excuse me, our residents to consider compensated shock and to really evaluate the patient closely if there's any concern for sepsis or other form of shock that may be developing. So that leads me to the physiology. And as I mentioned, I got a lot of lectures on shock when I was a resident. And then as I cared for patients in shock more often through my fellowship and started to learn a little bit more in comprehending probably a little bit more the physiology, I found this series of equations extraordinarily helpful in my understanding. So what you see here is that the delivery of oxygen, the DO2, is equal to the cardiac output multiplied by the content of oxygen in the arteries. So as you know, the little a is arterial. And so this is cardiac output times arterial oxygen content. Sort of as an analogy, many people oftentimes will describe this as a train car or a series of train cars. And so you can think of a train car as 25% full, 50% full, 100% full. That would be the content of the train car. And then the cardiac output would be the number of train cars or the number of trains being pumped out of the station per minute. And so that's helpful to me anyways. And I think about it, as what can we do to increase delivery of whatever is in those train cars. So obviously we're talking about the human body and oxygen, but in this way, you can say, well, if we fill the train cars up more, or if we are able to pump out more train cars, then either way, we can improve delivery to the end organs. But we have to break this down further to really understand what it means, okay? So cardiac output is pretty basic physiology and is equal to the heart rate and the stroke volume. So if you know, with each beat of the heart, you can pump out an extra 10 cc's or 20 cc's of blood. Then of course, there's extra red cells and hemoglobin in each of those cc's. And so you can improve oxygen delivery that way, or you can just, if the heart beats faster, then going back to the analogy, you're essentially pumping out more train cars. And so this now is how the body responds when it senses that oxygen delivery to its organs is inadequate. And the first and the fastest and one of the most effective ways to do that is to simply increase your heart rate. And we can see that oftentimes if someone jumps out, if your kid or somebody jumps around the corner and scares you, then very quickly your heart starts pounding. And so because your body is having this response, it's expecting to need more oxygen and to have more metabolic, that the metabolic demand is increasing. So it immediately increases the heart rate in order to improve oxygen delivery to the tissues that might need it as you run away. And then of course the heart is also pounding. It's beating harder, and that's in an effort to increase the stroke volume. And so I mentioned that here at the bottom, increasing contractility, but you can also, to some degree, increase the venous tone and increase your preload. And so this places the heart on a different place on the Frank-Starling curve, and perhaps you can increase your stroke volume that way. The slightly more complicated part of this equation is the arterial content. And at first glance, this looks like a complicated equation that would be impossible to memorize. But I think if we break it down, it becomes much easier to understand. So the first thing that I always mention when discussing oxygen content is the second parentheses. And so you can see that the partial pressure of arterial oxygen, so the oxygen that's dissolved in the serum, is multiplied by this very small decimal. So by doing so, the overall contribution of this part of the equation is relatively small. There are instances in which it becomes important, but for many practical purposes, you can sort of ignore this part, which means that we're going to focus on this first set of parentheses. And this very quickly becomes pretty simple because obviously 1.36 is a constant. And then hemoglobin and saturation are things that we think about with every patient, almost every patient. And so, a saturation is a vital sign. And then if you order any labs, you probably get a CBC or something, and you check a hemoglobin. And so this very complicated slide then very quickly gets broken down into things that are easy to assess at the bedside and that we think about commonly. Heart rate, stroke volume, hemoglobin, saturation. And those are the major components of oxygen delivery. So how do we assess this clinically? As I mentioned, heart rate is one of the quickest, most effective, and also one of the easiest ways to assess the degree of illness in a patient. And so we can always watch the heart rate. As I mentioned, it is a little tricky because the baby may be crying, the baby may be hungry, the baby may have a fever, but is otherwise okay. And so it's kind of hard to tease that out sometimes. But I would say that it's important to pay attention to the heart rate. And especially I want to highlight two specific instances. One is in infants. The heart rate, because they have a limited ability to increase their stroke volume, just because the size of the heart is small, then heart rate is particularly important to infants who need to increase their cardiac output. They can't increase their stroke volume by a significant degree, and so they rely extensively on heart rate. The other thing to keep in mind is athletes, and I think we've all seen a 14, 15, 16-year-old cross-country runner who maybe at rest has a baseline heart rate of 45 or maybe 50. And this is another thing that can make pediatrics confusing because we have to consider the patient's baseline heart rate. And so while 60 to 100 may be a normal heart rate for a teenager, if the patient's baseline is 45 and they come in at 95, then from a physiology standpoint, their heart rate is doubled for some reason. And that would be important to think about and trying to assess. The other thing that can make this challenging is that you may have these two patients right next to each other. So maybe the infant who is crying and hungry, or maybe even just comfortable with a heart rate of 130, and then the patient in the door next to them is a teenager with a heart rate of 95, and we're being asked to, pay close attention to the heart rate of 95 for the patient who may be, deteriorating with shock, whereas the infant with a heart rate of 135 is completely normal. And so that's what can make this challenging in pediatrics. You have to remember to think about the age, the patient's baseline, and just consider whether or not this heart rate is abnormal for that patient, and if not, is it a sign of ongoing critical illness? So the other thing is, oxygen content in the blood, and obviously the way that oxygen gets into the blood is by breathing. And so this, of course, is another way that the body can respond fairly rapidly, is if it's expecting to need more oxygen, then you can breathe more rapidly, or you can breathe heavier in order to try and increase the amount of oxygen within the alveoli, which then diffuses across the membrane into the blood. You can assess the skin and peripheral perfusion. Of course, you all are very good at that and experienced with that. Otherwise, you can try to assess markers of organ perfusion. So urine output is one. I know we oftentimes in pediatrics will ask about wet diapers and so on and so forth, but you can also assess the mental status. So is the patient obtunded? Are they somnolent? And if so, do you think this is a tired teenager because it's 2 in the morning, or do you think
I think Cody cut out for a little bit. Sorry about that. Let me see if he'll be back soon here. Sorry, we had some technical difficulties there, everyone. Cody is logging back in as we speak. Thank you for your patience. You'd think we'd get the hang of Zoom already, but not really. Thank you. Hang on.
Okay, everybody, sorry about that. I've been having some issues with my internet, and I was hoping to get through a 30-minute talk without any problems, but of course, it happened. So I just pick up where I left off. I assume, can you all hear me now? Is everything okay?
Yep.
Okay, thanks. Okay, so moving on to the surviving sepsis guidelines, and I'll try and get through this quickly, just in the event that that happens again. These were updated in February of 2020, as you can see in the bottom right-hand corner. And so I have a few things to highlight for you here, specifically regarding fluid therapy. So one thing I also want to mention is it's kind of crossed off by the red line here, but you can see that most of these are weak recommendations with low to moderate quality of evidence. And so, but it's the best we have. And so these are the recommendations based on the evidence we have. One is the campaign recommends using crystalloids rather than albumin for the initial resuscitation of children. And then they do suggest using a balanced or buffered crystalloid like lactated ringers rather than saline for the initial resuscitation. That being said, again, you can see that this is a weak recommendation with very low quality of evidence. At least I haven't noticed a big change in our practice in the PICU. We still continue to use primarily saline, I think mostly because there doesn't seem to be a lot of evidence to not do so, and it's readily available. Okay. And then with the availability of intensive care, they suggest doing 40 to 60 mLs per kilo in fluid boluses, which is pretty standard, something that we've been familiar with. They do differentiate this now as the availability or no availability of intensive care. And so I misinterpreted this the first time I read it, admittedly, and I didn't know exactly what they meant, but what they mean, anyone on this talk has the availability of intensive care. I'll just highlight here, with no availability of intensive care, they actually recommend maintenance fluids instead of fluid boluses for patients who have good blood pressure, but those are, again, usually in the developing world. And so with access to intensive care via rapid transport, you would do the 20 ml per kilo boluses up to 40 to 60, depending on the patient's condition, until transport can be done. Vasoactive medications. This is, point number one. They're unable to issue a recommendation for a single specific first-line vasoactive infusion. However, what they do say is that probably epinephrine or norepinephrine are going to be your first two choices rather than dopamine, which I believe was previously preferred. So basically, you can keep in your head epi or norepi, choose one or the other. They don't differentiate between those two, but those are probably your top two. Okay. That being said, dopamine can be substituted as a first line if either epi or norepi are not available. And finally, it's reasonable to begin these infusions on your second or third bolus. Probably, if the patient isn't responding on the second bolus, you probably need to get that ordered and started while you maybe plan for your third bolus. And a question we often get is, can this be delivered through a peripheral vein? For initial resuscitation, epi and norepinephrine can be administered through a peripheral vein, which is how patients usually come to us. So they can't tell you exactly when to intubate the patients. That, of course, goes along with a lot of clinical decision-making. But what they do say specifically in these guidelines is not to use etomidate. Etomidate has, as you probably know, has been shown can induce adrenal suppression. And so they say we suggest not to use etomidate when intubating children with septic shock. If you are beginning mechanical ventilation, I have a little chart here of just a few initial settings that you may want to consider. Obviously, it requires reassessment and titration based on a chest X-ray and blood gas, but this is a general starting place. First of all, and this is from Pediatric Fundamental Critical Care Support, the 3rd edition, which was a recent update, and we're hoping to host again in May. But they suggest you choosing the mode with which you are most comfortable. That being said, we usually use SIMV PRVC with pressure support. The tidal volume, you're going to want to select between 6 and 8 mLs per kilo. So if you have a 10-kilo child, it'll be somewhere between 60 and 80 mLs of tidal volume. But you may find that you need to titrate this if the patient is over or under ventilated when you get the blood gas a few minutes later. But 6 to 8 is something to remember. The PEEP usually starts at 5. If you get a chest X-ray and you find that they have atelectasis or you're having difficulty with oxygenation, you can increase that to 8 or 10. And then a respiratory rate. This is probably the high end of normal for each of these ages, but I think these numbers are just easy to remember. So you can think, 30, 25, 20. So infants, 6 to 8, up to 6 to 8 months, maybe you start at 30. Toddlers and preschoolers, 25 breaths per minute, and older children, 20 breaths per minute. And again, you'll have to get a blood gas to reassess that, and you may need to turn that up or down, but this is at least a starting point that you can remember without having to put too much thought into it when you're, in a stressful situation. The goals for ventilation. So when should you increase the tidal volume or decrease the tidal volume? When should you increase the rate? Your primary goal is a pH, they say in PFCCS, near normal. They didn't give a specific number, so I just put in 7.3. So a pH of greater than 7.3, even with a CO2 of 55, is acceptable. And then secondarily, you can maybe aim for a PCO2 in the normal range of 35 to 45 or 40 to 50, something like that. And then finally, FiO2. You're initially going to start your FiO2 at 100%. But again, according to PFCCS, you want to titrate that oxygen to maintain an oxygen saturation level of 92 to 94%. I believe, if I'm not mistaken, there was in one of the recent issues of Pediatric Critical Care Medicine, there's an article that discusses that hyperoxygenation actually has worse outcomes. And so it's okay to wean the FiO2 to maintain SATs in the mid-90s. You don't have to have 100%. I see a quick question in the box. I'm just going to address that here while we're on the slide. For this situation, up to what age is etomidate not recommended? All pediatric? I would say yes, all pediatric. I have probably only used etomidate in a handful of situations. I think one situation what it is really good for is traumatic brain injury, because it's hemodynamically stable. And if you have just a isolated traumatic brain injury, then they're less likely to go into shock. But we typically don't use etomidate often in pediatrics if we have any concern at all that there is a septic picture. Oops. So I didn't red box to highlight anything on this because all 3 points are pretty important. They say in patients with septic shock, well, let me go to number 6 first. It says, if you have sepsis associated organ dysfunction, but without shock, they say antibiotics within 3 hours of recognition. However, in patients with shock, which you have probably heard before, you want as soon as possible and definitely within 1 hour. And they always say, please do not delay antibiotic administration in order to obtain blood cultures. If you can obtain blood cultures while getting your IVs placed and so on and so forth, that's fantastic. But don't delay antibiotic administration in order to obtain blood cultures. And then of course, you're going to choose very, very broad spectrum antimicrobials. We do use ketamine sometimes. It sort of depends on what's going on. So if we have a patient just in respiratory failure for RSV, oftentimes we'll use fentanyl and Versed as our induction agents. But if we have concerns that maybe this patient is in shock or is at risk of hemodynamic instability, then ketamine is a reasonable choice as well. This is the algorithms provided by the Surviving Sepsis campaign. You can see that basically what we just went over here is now shown in these figures. So you can see the sepsis suspected. You want to begin an expedited diagnostic evaluation and complete all of these steps within 3 hours of initial suspicion. However, in shock, you want to complete these steps within the 1 hour. And then I'll also highlight here sort of this continuous reassessment of the respiratory status, the cardiovascular status with the titration of the fluids and vasoactive medications, central line or arterial line, and then antibiotic administration. And then this is referring to, again, the choice of vasoactive infusion. And essentially, it just sort of says the same thing that we already mentioned, which is that your first choice is going to be either epinephrine or norepinephrine. The single caveat that they sort of describe here is in the 4th bullet point, is that if you suspect myocardial dysfunction, so perhaps a patient with decreased LV function due to their MISC, then probably you want some inotropic support and you would consider using epinephrine as your first line. However, if this is sort of your run-of-the-mill, so to speak, septic shock, then again, either epi or norepi are reasonable as your first choice. So how does this fit in? The beginning, the very beginning introduction slide said we were going to talk about this in the setting of coronavirus disease 2019. And essentially, the take-home points are very simple. One is your clinical assessment is the same. And the second is that even if you suspect that the patient's symptoms are due to MISC, you're going to follow the same Surviving Sepsis campaign guidelines for resuscitation as you normally would, with the single caveat, as I mentioned, that maybe epinephrine would be slightly more preferred over norepinephrine as for ventricular support. Okay, so getting back to the objectives here, and just to sort of summarize what we discussed, One is we talked about the definition. So we know that shock is inadequate oxygen delivery to tissues. We discussed the multiple etiologies, and we discussed the differentiation between compensated and uncompensated shock, because we know that early recognition is crucial, and we want to try to intervene on the patients before they deteriorate. We discussed the physiology of oxygen delivery. We noted that it's the result of cardiac output and oxygen content. And we sort of discussed how the body responds in order to improve oxygen delivery to the organs. And then finally, we went over a series of recommendations from the Surviving Sepsis campaign regarding how to replace circulating fluid volume, how to support the respiratory status, how to support the cardiac function, and finally, the importance of antibiotics. And with that, I'm a couple minutes over time, but I'd be happy to take any questions that you have.
Awesome. Thank you so much, Cody. I think that was great. A great review of managing and recognizing pediatric shock in general. I do think that for me, my biggest takeaways from your talk is that MISC shock can look a lot like septic shock. And I do think that it's going to be hard to differentiate them in the ED. So I do think that the current recommendations, like you said, would recommend treating a septic shock until proven otherwise. And that the early consideration for cardiac involvement is really the biggest change from the Surviving Sepsis Guidelines in this era of MISC as a potential differential, and using epinephrine instead of norepinephrine to give a little bit more inotropic support. So I think those are the main takeaways. Also glad that we had a discussion about etomidate versus other induction agents for sepsis. I do think that this is something that we see not uncommonly for patients that have been referred to our ICU. So it's great that we're having that discussion about whether or not to use it. And I would agree with Cody, ketamine is probably what most intensivists will use for intubation for somebody with suspected sepsis. Any other questions for Dr. Tigges before we move on to our next presenter? All right, if you guys think of anything for Dr. Tigges, please feel free to put it in the chat. We're gonna move on, and I am very happy to introduce Dr. Sandy Hong, who is one of our pediatric rheumatologists. And Dr. Hong has been really invaluable to our practice, both in the ED and in the PICU, given her expertise. So Dr. Hong, aside from being a fantastic colleague, is also the chair of the American Academy of Pediatrics Section on Rheumatology Executive Committee, and she is the co-author of one of the American Academy of Pediatrics MISC guidelines. So we are very fortunate to have her today to talk with us about MISC. So thank you for being here, Sandy.
You're welcome. Can everybody see my screen? Did I share the correct screen?
Yes, you did. Looks good.
Okay. Well, I'm here today to talk to you about MISC. Let me see. Oh, interesting. I don't have any disclosures. I will talk about unapproved or investigative use of drugs, because that's all of pediatric rheumatology drugs. I think the goals of today's talk are to discuss what is MISC. We'll go over when you should have clinical suspicion and start evaluation for MISC. And I'll talk about tier 1 and tier 2 testing, depending on where you are. I think tier 1 testing is more appropriate if you're in the outpatient clinic and you have a very stable patient. And then tier 2 testing is more appropriate if you have a very ill appearing patient, or you're in the ER and you are heading towards admission. We'll talk about treatment for MISC, the expected clinical course, and then complications and outcomes. So the key points of today's talks that I'd like you to walk away with, if you walk away with nothing else, is that MISC is a post-infectious inflammatory immune response, and there's two main clinical phenotypes. The first is most similar to toxic shock or KD shock, and it has features of fever, abdominal pain, and rash. And the second phenotype is more associated with what we call incomplete Kawasaki's disease phenotypes. These patients present with features of fever and mucocutaneous rash. Now, I think you should have a high index of suspicion for MISC if you are seeing a patient with fevers, rash, abdominal pain and diarrhea, and a recent history of COVID-19 infection or exposure. And what I'd also really like you to take away is if you have a patient who has low blood pressure, tachycardia, tachypnea, for age and evidence of poor perfusion, i.e. you suspect that they are in compensated or uncompensated shock, that they should be moved to the ER setting, and they should be somewhere where they can have quick access to a PICU. Okay. So the first cases of MISC actually were in Spain and Italy, and they occurred in late February and early March of 2020. These patients presented with fever, septic shock, and hyperinflammation with elevated CRPs and ferritins. Verdoni et al. Was one of the first people to report this, and they have Europe has also a consortium, and he reported to the consortium, hey, I've seen 30 times more KD than expected. So obviously the Italians are what you call lumpers, right? They saw this new thing, but they said it's most like Kawasaki's disease. He saw 10 patients who presented with these Kawasaki disease-like features, and he said half of them met full criteria and half of them didn't. They showed up with LV dysfunction and they had coronary aneurysms. 50% of them were hypotensive, in shock, had to go to the PICU. And what's interesting that I find is in February and March, in 2020, they were able to check antibodies, and 8 out of 10 of these patients had COVID antibodies. And 2 out of 10 were PCR positive, and 2 had, they were PCR and antibody negative. But this is the data from Verdoni, and he said, look, here's my Kawasaki's disease from 2015 to 2019. The blue is like classic non-severe Kawasaki's. The pink is that they're severe, they have hypotension. And what you'll see is in 2020 of March, all of a sudden he had these group of very sick KD kids. And so he compared group 1, which is everybody before 2020, with group 2, which was everybody that showed up between February and March, April of 2020. And he said, what's the difference? Well, the patients in the new group, group 2, were older. They were 7.5 compared to group 1, which is your classic KD kids who are toddlers. These patients had lymphopenia, thrombocytopenia, and very high ferritins. They also noticed that a large majority of them, 60%, had abnormal echocardiograms, being mostly LV dysfunction, and they had to give steroids to them. The bottom graph here is ED admissions during February and March of the pandemic for his group. And if you look, there was a lot of admissions here, and these were mostly URIs. And as the COVID URI patients stopped being seen so much, that's when these, the arrows show you, that's when these Kawasaki's disease patients started showing up. So he also noted right away, this didn't happen at the peak of the viral infection. This happened after the peak of the viral infection. So after Spain and Italy were reporting the cases, the UK also saw 8 cases in a 10-day period. And again, they saw patients with fever, rash, conjunctivitis, peripheral edema, generalized arthralgias, myalgias, significant abdominal pain with nausea, vomiting, or diarrhea. And all these kids progressed to shock requiring vasopressors. And they didn't have the cough and cold that you would, or respiratory symptoms associated with acute COVID-19. Many of these patients were Afro-Caribbean, and they were, again, older than the classic young KD patients. So after these patients were seen in the UK, there was a worldwide alarm, and the World Health Organization, the CDC, and the UK made case definitions for MISC. And we'll go over the US case definitions. We're not going to go over this busy slide. I just want you to know that at that point, everybody said, okay, we need to make a case definition for this new thing. Really quick, I want to talk about Kawasaki's disease because we're going to be comparing it a lot to MISC. Because for a rheumatologist, I understand it as being a very, and it's not exactly the same thing, but it's a similar immune process. So for me, I see Kawasaki's disease not as a disease, but a phenomenon. And so when the COVID stuff started happening, I was like, and MISC came out, I said, yeah, this makes sense. This is a post-infectious immune response. So Kawasaki's disease is a post-infectious immune response that causes systemic inflammation. So it causes, to get diagnosed with Kawasaki's disease, you have to have fever for at least 5 days. You have to have 4 out of 5 of these clinical features. You should have rash, which is usually maculopapular, but could be urticarial. You have to have conjunctivitis. You have to have mucocutaneous changes. And by that, we usually mean what we refer to as the strawberry tongue. You have to have adenopathy. And then these patients usually have thrombocytosis, very high platelets, sometimes up to 1 million. And then they can have coronary artery dilation, which is why it's so important to catch these, because these patients can have coronary artery dilation that then moves on to aneurysm. And we do know that there is a genetic predisposition to Kawasaki's. In Japan, 309 out of 100,000 kids per year between 0 and 4 get Kawasaki's. In the Caucasian population, it's only 14.7 per 100,000 per year. And then here in the US with our mixed population, it's about 25 per 100,000 per year in patients 0 and 5. And Kawasaki's disease it's important to know that and recognize it's the leading cause of acquired heart disease here in the US for children. We think that it's set off by environmental triggers, Candida, Neisseria, strep, adenovirus. And we see about 5,000 hospitalizations for Kawasaki's disease a year. And we understand that the pathology of Kawasaki's has like a triphasic changes. First, there's like a neutrophilic arteritis, then there's a vasculitis, and then after the vasculitis, there's luminal myofibroblastic proliferation. And we know that TNF and IL-1 cytokines are essential for the development of the vasculitis and the cardiac inflammation. Untreated KD sees 25% incidence of coronary arteritis. We treat KD now with IVIG, aspirin, steroids, TNF inhibitors, and IL-1 inhibition. And with treated KD, we only see coronary artery aneurysms of 3 to 6%. So that's a win. So as a rheumatologist, I've always recognized Kawasaki's as a kind of a spectrum or a syndrome, because there's always been a microphenotype where we would see older children with abdominal pain, features of shock and hypotension, and thrombocytopenia instead of thrombocytosis. And there are multiple case reports of these kids. The other thing that as a rheumatologist we've seen is patients presenting with Kawasaki's disease and then developing macrophage activation syndrome, also known as cytokine storm, where their immune system is just vomiting and they become multi-organ failure due to this cytokine storm. So the way that we think about this is that depending on your immune response, the more intense your immune response, the more likely you are to get the worst features of cytokine storm or MAS and shock. So when MISC first became known, it was called PIMS in the UK. Jane Burns, who has the Kawasaki's disease database, and Mike Levine, who has the European fever database, actually merged their databases and looked at features of KD and fever and compared it to the MISC cases that were reported and tried to compare it to the KD shock cases that we reported and tried to also compare it to the toxic shock. And I'm sorry, this graph, the numbers are small, but I'll just point out to you that, you have 1,000 KD kids and only 45 KD shock and, 37 toxic shock. But what they could find out was that they noticed that the median age of MISC was higher than expected for KD. They noted that there was no difference in white blood cells or neutrophilia that they could see. They did also note, yes, there's increased lymphopenia in MISC. The patients are more anemic and they're more thrombocytopenic in MISC and toxic shock. What they also noticed that the CRP is much higher. This is a graph for CRP, is much higher in patients with MISC compared to KD. There is more hypoalbuminemia. There's no difference in liver function tests. There is more hyperferritinemia, more elevated troponins, and more elevated D-dimers. But to be fair, we don't really check troponin and D-dimers and ferritin in patients with KD prior to this pandemic. I think now that the pandemic is here, these markers are being checked in, all KD patients too. So MISC is not exactly like Kawasaki's disease, but it's similar, right? It's a post-infectious inflammatory response syndrome specifically associated with COVID-19. And because of that, you're going to see the nuances that we've figured out of lymphopenia, thrombocytopenia, hyperferritinemia, low albumin, and very high CRPs. So based on that data, let's look at our American CDC case definition for MIS-C. It's any individual less than 21 years of age. And for those of you who may be seeing adult patients, it's MIS-A if you're 21 or over. You have to have laboratory evidence of inflammation. You have to have severe enough disease to require hospitalization to be called MIS-C. Usually there has to be at least 2 organs involved: cardiac, renal, respiratory, hematologic, GI, dermatologic, or neurologic. And I'm going to tell you, as time has gone on, what we've noticed is that the respiratory symptoms aren't really there. We think that the patients with the respiratory symptoms may be kind of lingering acute COVID infection that just hasn't resolved. And some of the patients then flip into MIS-C. So you have to have no alternative plausible diagnosis. So, you shouldn't have shock from other reasons. And you should also have evidence of having SARS-CoV-2 infection, either by PCR, serology, or antigen test, or at least have epidemiologic exposure. So the case, as far as fever is concerned, you have to have fever for at least 38 degrees Celsius for over 24 hours. The CDC does allow you to report subjective fever. You should have laboratory evidence of inflammation, increased CRP, ESR, fibrinogen, procalcitonin, D-dimers, ferritin, IL-6, lymphopenia, and neutrophilia and hypoalbuminemia count. If it meets criteria for Kawasaki's and there's evidence of COVID infection, the CDC initially asked that this be reported as MIS-C, and then the CDC also asked that any patient who dies of SARS-CoV infection, that to look at it, to review these cases to make sure that they weren't actually MIS-C patients. So what evidence do we have that MIS-C is immune-mediated? Well, we have the epidemiologic evidence. We've seen the delay of onset of MIS-C patients clusters after peak community infection. We saw this in Italy, the UK, New York, and Boston. And the other thing is, I would say that the majority of MIS-C patients that we've had have been COVID antibody positive. It's almost a criteria now, as far as I'm concerned. And we know that patients don't make antibodies until they've had 1 to 3 weeks after the initial infection. Okay, this graph here is just to show you the onset of MIS-C after the peak of the population infection has started to go down. This was from 2020, as you remember that in April and May, New York was hit first, and they were the ones to see the biggest MIS-C cases, and they all occurred after their peak in April. The Boston cohort had a similar delay in peak. They had 28 patients with MIS-C, and they looked at their cohort. They noticed that 25% of them didn't meet criteria for Kawasaki's disease or incomplete Kawasaki's disease. But what's interesting about this cohort is that they noted that 2 of their patients had previously had Kawasaki's disease. I thought that was pretty interesting. No one inflammatory marker was elevated in all patients, but each patient had at least one elevation in ESR, CRP, procalcitonin, or ferritin. The other important thing that the Boston cohort noted was they saw a lot of LV dysfunction. They also saw a lot of coronary artery dilation, and they noted that the BNP levels were inversely correlated with cardiac ejection fraction. And we've seen this here, I think, at the university, that when patients have very elevated BNP levels on admission, that they're the ones most likely to have LV dysfunction on echocardiogram. So Boston too said, maybe with Corona, we won't see regular KD, and that wasn't true. What they've noticed is, what Boston noticed and we've noticed here is you're going to see your regular amount of KD patients, and then you're going to see MIS-C on KD phenotype on top of it. So this is the ACR clinical guidance for evaluation of MIS-C. I just wanted to make you aware of it. So, I don't expect you to remember everything from this talk, so you can find it yourself. ACR stands for American College of Rheumatology. If you just Google ACR clinical guidance, this will come up for you. And we're going to go through this in detail. So when should you be suspicious for MIS-C? Well, the first requirement is that if you have a patient with a fever, you can think about it, but you're not that excited. But then when you're like, oh, you all had COVID last month. Oh, okay. So you all had COVID, 2 weeks ago. Then I think your spidey sense should come up. It's like, oh, they've had recent COVID exposure. And then you should at least have 2 suggestive clinical features. And this is rash or GI symptoms, abdominal pain, vomiting, diarrhea, The patients may present with edemas of their hand or feet. You should have features of oral mucosal changes, and most often this is the strawberry tongue. You should have conjunctivitis, and this doesn't have to be limbic sparing. So in Kawasaki, sometimes the conjunctivitis is limbic sparing. You'll see like a little white arc around the eye, and that's very classic for classic KD. You don't necessarily see this in MISC. You don't, and you may have lymphadenitis, and neurologic symptoms are also very common. The most common is headache and irritabilities. Some patients with MISC have presented with encephalitis and seizure and stroke. But I'm going to tell you right now, clinically, when I talk to most of our patients that have been admitted, it's interesting how many of them, the first symptom is actually headache. Oh yeah, we had COVID, a month ago, we were all fine, runny nose, totally got over it. And then the patient will suddenly out of nowhere complain of headache. The next day develop abdominal pain, and maybe the day after that get fever and maybe vomiting, maybe diarrhea, maybe not at all. And then they'll show up hypotensive. Okay. So this is by Young et al., and this is the different mucocutaneous and rash manifestations of MISC. This little boy in A here has the conjunctival injection and the malar erythema. This boy has a strawberry tongue. This child presented with like a scarlatiniform rash. It looks like scarlet fever. And this patient had more the typical morbilliform eruption. This baby had like a reticulated libido rash. This one, sorry about that. This one showed up with urticaria as his presenting rash. And this child here has periorbital edema. And I want you to really look at this periorbital edema. I'm going to tell you like 90% of the patients with MISC that I have seen have had periorbital erythema and edema on admission. And as they get treated, you just watch it slowly fade away and go back to normal. So this periorbital edema has been very common. And then the erythema of the hands and feet, of course, are very common. So really quick, I just want to go over again these two phenotypes that we're going to discuss, the two phenotypes. But initially, the CDC in August put out phenotypes of 570 patients that were seen and reported between March and July of 2020 to the CDC. And initially, they reported three phenotypes, class 1 being the abdominal pain and shock phenotype, class 2 being like more of a respiratory symptoms phenotype, and then class 3 being the more classic Kawasaki's phenotype with the mucocutaneous changes. So the class 1 was phenotypically like KD shock. These patients, median age was 9. 50% of them had 6 or more organs involved. They all had cardiac involvement, and they all had GI, almost all of them had GI involvement, and they all were SARS-CoV serology positive, plus or minus PCR. So clinically, again, these patients had abdominal pain, nausea, vomiting, diarrhea, shock with myocarditis, lymphopenia, elevated CRP, elevated ferritins, elevated troponins, and BNPs. And then class 2 was a mucocutaneous phenotype that we've talked about. These patients had a median age of about 6 years, so not as young as our toddlers. They had the highest prevalence of rash with mucocutaneous changes, and they had about 18% coronary artery dilation. Only 6% of these patients met full criteria for KD. I'm going to tell you what I've found missing most of the time was the adenopathy. So if you look at the characteristics of these patients, let's just focus on class 1 and class 3. What I want you to notice is that in class 1, half of these patients had elevated BNPs on admission, as compared to class 3, their BNPs weren't, they were less likely to have elevated BNP. I would say that more patients in the class 1 shock phenotype had cardiac dysfunction, 53% compared to 21% of class 3. But what I found interesting is, and the myocarditis was also higher in the class 1 shock phenotype. But what I found interesting is like all of these patients, no matter what class they were, had coronary artery dilation and aneurysm. So it's very important that all of these patients have echoes and monitoring ongoing. Okay, so clinical evaluation for MISC. So you have a stable outpatient, they have normal vital signs. You could wait till day 3 of fever before you do tier 1 testing. However, if the patient is ill with fever, low blood pressure, tachycardia, tachypnea for age, low O2 sats, poor perfusion, or altered mental status, and they're unable to maintain their PO hydration, I think that tier 1 and tier 2 testing should be done. And if they look that sick, they should probably be transferred to the ER for the tier 1 and tier 2 testing. So tier 1 testing is CRP and ESR, CBC with diff, CMP, and please do SARS-CoV PCR testing and serology testing, looking for spike protein and nucleocapsid antibodies. At this time, most patients also get testing for the differential diagnosis of MIS-C, which is other viral infections, strep infection, and influenza. And depending on how ill they are, blood and urine cultures are being done. So you should have increased suspicion for MIS-C if you have evidence of inflammation with increased CRP or SED rate, CRP greater than 5 or SED rate greater than 40, and at least one suggestive lab abnormality, either lymphopenia with an ANC with a lymphocyte count less than 1,000, thrombocytopenia, so less than 150,000 platelets, hyponatremia, neutrophilia, or hypoalbuminemia. And what I find interesting is by the time the patients get admitted to us, they actually will have 2 or 3 of these criteria will be off. So tier 2 criteria is, okay, you've done tier 1 and you're like, okay, I'm really suspecting MIS-C. So now I need to add on or run the pro-BNP because you're looking for evidence of LV dysfunction and myocarditis. You're checking a ferritin to look for cytokine storm features, and you're checking clotting diathesis with PT, PTT, and D-dimer because we do know that some patients with MIS-C have clotted and stroked. Additional studies, if you're running tier 2, is thinking, okay, this child is going to need an echo and EKG. Where do I get them to get this done? And then, of course, blood and urine cultures and chest x-rays are being done at this time too. Now, I'm a rheumatologist, so I have to talk to you about ferritin. You know, if you call me about a possible MIS-C case, you know I'm going to ask about ferritin. And because for me, if the ferritin is a good marker of incipient macrophage activation syndrome, we have seen cytokine storm or macrophage activation syndrome in patients with MIS-C. So you guys have all heard of the Baker-Wong pain facies. Well, I developed the pediatric rheumatology ferritin facies scale for you. If a patient's ferritin is like 50 to 400, I think of this as an acute phase reactant. You know, usually when a patient is sick, the ferritin goes up so that it can bind iron so that the iron is not available for bacteria to use. And so it's a protective mechanism. But ferritin is interesting because it's also an immune signaler. And when you have immune activation, your ferritin will go higher. And so ferritins between 400 and 800 are abnormal. We usually see this in infection sepsis, systemic GIA, and now MIS-C. And as your ferritin goes higher, your rheumatologist starts getting more worried. And any ferritin greater than 1,000, I think you should be thinking that you should be talking to a rheumatologist because they might need more medications to treat incipient cytokine storm. So MIS-C treatment does require a multidisciplinary team. Many patients are co-treated with antibiotics during the initial diagnostic evaluation, especially if they show up with septic shock, because we're never sure if they are E. coli sepsis or some other sepsis. Then initially we treated MIS-C. People said, well, you can use IVIG or you can use steroids, and we think they all do this well. I actually have always treated with both most of the time because I think the patients were very sick and I didn't want them to get sicker. I also wanted to turn off the immune activation as fast as I could. And the ACR put out new guidelines actually 2 weeks ago, and they now recommend IVIG plus steroids for MIS-C treatment. Our IVIG dose is 2 grams per kilogram, and the infusion is dependent on cardiac status and fluid status. Most patients who go to the PICU with LV dysfunction, we split their dose. We give them 1 gram per kilogram the first day and then 1 gram per kilogram the next day with a max of 50 grams each day. The other thing, steroid therapy, 1 to 2 mg per kg per day is recommended. I tell you that here we tend to start on the higher end. And for very sick patients who, or refractory patients, we will give them steroid pulse dosing, 30 milligrams per kilogram per day with a max of 1 gram. I will tell you that I tend not to pulse until I know that they're not having bacterial sepsis. And then use of biologics is usually determined by rheumatology for refractory MIS-C. And I'll also because if you remember that when I was talking about KD, that we know that TNF and IL-1 are necessary for the vasculitis and formation of aneurysms. If patients have dilation and very bad cardiac disease, I'll sometimes add on IL-1 inhibition to prevent them from making aneurysms. And then TNF inhibition is used. What's interesting is when MISC first came out and everybody was using Actemra, the IL-6 inhibition for acute COVID, we were like, should we use this for MISC? As time has gone on, I think most of us have used IL-1 or TNF inhibitors. Now, the new ACR guidelines that just came out also suggest that all MISC patients be started on low-dose aspirin, and then anticoagulation therapy is done per hematology, and we do use low molecular weight heparin for some of our patients, and we'll talk about that more. So this is just the pathway for the ACR guideline for treatment that we've just discussed. So when a patient is admitted with MISC, they should have echocardiogram. If they're going to the PICU, we try to get the echo within a few hours of admission so that we know about whether they have bad LV dysfunction or not. If they're stable and on the floor, we can wait till the next day to get the echo. We do recommend that echoes be repeated prior to discharge if there is ventricular dysfunction or dilated coronary arteries. And if a patient has a normal echo on admission, we do recommend repeat in 7 to 14 days and at 4 weeks, because some patients have, just like Kawasaki's, have developed aneurysms and coronary dilation after discharge. Now, we also recommend that patients with abnormal BNP and troponins and ferritins have these lab trended to normalize. And if a patient's admitted, we do recommend an EKG on admission and every 48 hours, because some patients have developed arrhythmias, with the most common one being first degree AV block. So as far as anticoagulation is concerned, it was really funny because during the very first meetings for MISC, I remember sticking my hand up and asking about anticoagulation, and nobody would answer. But now we kind of have a consensus that everybody should be put on low-dose aspirin. You don't need the aspirin at anti-inflammatory treatment, because we're already doing steroids and IVIG. The aspirin is more for antiplatelet and therapy. And so we do low-dose aspirin as long as their platelets are greater than 80,000 and they're not at risk of bleeding. This should be continued at least until 4 weeks after discharge, with normal coronary arteries confirmed via echo by cardiology, and until the platelet counts are normalized. All patients are treated with low molecular weight heparin if they have thrombosis, D dimers greater than 3 milligrams per milliliter, poor ejection fractions, giant aneurysms, or arrhythmia. And anticoagulation is continued until they're cleared by cardiology, or their D dimers have normalized and they're cleared by hematology too. So some of the complications of MISC, patients, we do very well. We save our patients, they live, but some of these patients have been hospitalized for 5 to 14 days. I would say the average is at least 7 to 10 days. They require PICU care. The number of patients requiring PICU care is anywhere from 20% to 70%, depending on when you catch the children. The patients often get vasopressors when they're in the PICU. We've had many patients sedated and intubated. Luckily, ECMO does happen, but it's rare, and dialysis is rare, and death is rare. Long-term outcomes, most of our patients actually have improvement in their LV dysfunction prior to discharge. Just treating them improves the LV dysfunction almost within days. Cardiac MRIs have shown reversal of the myocarditis in the majority of patients with cardiac follow-up as outpatients. We don't know the long-term cardiac risk of MISC. Is this like KD? Is this another acquired, do you get counted as acquired heart disease? And, and then we do know that patients have had strokes and clots with MISC. So outpatient follow-up with MISC, they have very close cardiology follow-up, and they should have lab follow-up. A lot of the times I will see them 1 or 2 more times just to make sure that their inflammation is turned off. And then I will release them to follow up with cardiology. And it's the same with hematology. They will be followed to make sure that their D dimers, for those who didn't clot or have aneurysms, have normalized, and then they're released by hematology. But as you can see, if you have MISC, the follow-up for cardiology is quite intensive. You need to get seen, 7 to 10 days later or 2 weeks later, and then 4 to 6 weeks later. And these involves echoes and EKGs. And then depending on, how bad your cardiac disease was, you're going to need to be followed, 4 to 6 months later with echoes, EKGs, and maybe Holters, stress testing, cardiac MRI, and then 9 to 12 months later. And so, cardiology is still feeling their way through this, but I think here Rabia Khan, who does most of our MISC patients, has definitely developed a protocol for how she deals with these children. And the thing that stinks about MISC is that for many of our patients who have been wrestlers and basketball players, is that they have 3 to 6 months of exercise restriction, where they don't get to do what they want to do because they've had MISC. And even in our kids without cardiac involvement, they have a 2 to 4 week minimum restriction because they need to get cleared by cardiology and make sure they haven't developed aneurysms after discharge. And then, once a patient has had MISC, I do talk to the parents. I'm like, heart healthy diet, minimize other cardiac risk factors. You don't want your child to grow up and be obese. You don't want them to smoke, and if you don't want them to be hypertensive, you've got to control that. So how common is MISC? Between April of the pandemic of 2020 and 21, every couple of months, I would do like calculations, and I would calculate about 1 per 1,000 COVID positive reported pediatric patient. So, that's like, it's got to be lower, right? Because there's all these pediatric patients who had COVID and never even got tested. And so I figured, well, okay, 75 million children in the US, that should be about 7,500 kids, and 700,000 kids in Iowa. We should see about 70 cases. Well, as of yesterday, we have seen 70 cases of MISC here at the University of Iowa. So I know that there are cases that have been seen at other hospitals. I know Blank has seen at least 15 or 20 cases. So I think it's higher than 1 per 1,000. But then we started vaccinating kids, right? So didn't this help? The CDC as of January 31st has 6,851 reported cases with 59 deaths, very low fatality. So the questions that this makes me ask is, will MISC be like Kawasaki's? Will it be seasonal? Does the vaccination protect against MISC? And will this change with new variants? Does it protect you just one season? Or will it, if you get the 2-dose series, does it protect you for years? I don't know the answers to this, but these are the questions that I'm going to be asking. This here is a graph of daily MISC cases in blue with COVID-19 cases reported. It's a 7-day moving average. Just remember that in the beginning of the pandemic, we couldn't test people. We couldn't get testing. But I find it interesting. And if you look here at the end of December and January, you see the big Omicron peak. I'm just wondering what the COVID peak is going to look like. Maybe everybody was already infected and we're not going to get a huge peak, but all of us are kind of holding our breath right now to see what's happening next. This here is actually a graph of the cases of MISC that we've seen here at the University of Iowa. On top here, this is the first variant, and here's the Delta variant, and here's the Omicron variant. And you can see there was a spike in January, right? The dark blue color is our patients with the shock and who had to go to the PICU. The light blue are our patients who had the mixed features with abdominal pain, but they didn't show up with shock. And the orange color is KD, classic KD features, and the pink color is the KD patients who didn't quite meet KD criteria, but they did have mucocutaneous changes. And what I thought was interesting was the first wave, it was kind of 50-50, right? I saw half KD patients, half the shock patients. With the Delta variant, we saw so many KD shock. I don't know what it was about that variant, but the majority of our patients had abdominal pain, and there was a lot of KD shock. And then with the Omicron variant in January, I just noticed, hey, we've seen a lot of toddlers and a lot of younger kids, less than 5, who showed up with more mucocutaneous changes. And there were, of course, the abdominal pain patients, but less PICU patients, right? And so I don't know if we've gotten better at recognizing MISC and we're getting them before they need to go to the PICU, or it's just a differentiation in variant. So vaccination and MISC, there's 2 papers that do support that vaccination appears to protect against MISC. There was a CDC case control study done that was published in January of this year that showed that 2 doses of the vaccine appear to be 91% effective against preventing MIS-C. It's not perfect. There was a French study that looked at MIS-C and their vaccination rates. And this is what was interesting. So the French, by October of 2021, 72% of their adolescents were vaccinated. I think this is really good. And so then they looked at between September and October of 21, they had 107 patients admitted with MIS-C. And what is interesting about these patients is 31% of these were eligible for vaccination and they weren't. 0 patients were fully vaccinated. 7 of them had received 1 dose. You know, this is the Delta variant for them, and 80% of these patients ended up in the PICU. So what we can get from these 2 studies, it looks like vaccination is protective against MIS-C, but I think you have to finish your course at least 4 weeks prior to infection, because here at Iowa, we've had 2 kids that were vaccinated. One of them had MIS-C like a week after his 2nd dose. And I'm sorry, he had nucleic capsid antibodies. So he got infected somewhere in between during his series. And then I think it was similar for our other patient who was vaccinated. So, you know, when parents ask me, well, should I vaccinate my kids? We know that they're not going to die. I mean, you know, especially when the 5 to 11-year-old vaccine came out. And I want you to look here. This is MIS-C patients by age group. This is data from the CDC. The biggest age group is the 5 to the 11-year-old age group. So when parents ask me about vaccination, I say, yeah, you don't want to end up in the PICU. Okay, I'll stop there. Here are resources for evaluation and treatment of MIS-C. There are the AAP guidelines. There's the ACR guidelines. There's the CHOP clinical pathway and the Children's Minnesota MIS-C guidelines. They basically all say what I just told you. But they're there for you if you want to see them. And I'll stop now and answer any questions people have. I'll look at the chat.
Thank you, Dr. Hong. That was a really nice overview. I don't see anything in the chat, but I do have a comment/question.
Okay.
One of the things you said that stuck out to me, particularly given the recent Omicron surge, is that the history can sometimes be pretty subtle. And anecdotally, I think we've even seen some patients in the PICU who families will say, well, we've never had COVID and we've never had symptoms, and yet based on lab testing, it shows that that's not the case. And so then we're kind of left guessing when their infection might have been, but we can put it all together if the labs are also consistent with MIS-C.
Yeah.
And so it seems to me, one of my takeaways from what you were saying is that for frontline providers in the emergency room, that keeping MIS-C in mind and maybe adding the tier 1 and maybe tier 2 labs to their routine practice for patients who come in ill appearing and febrile would be a very reasonable thing to do, you know, at this point in time. Would you agree?
Yeah, I think ill appearing and febrile, but also they should clinically maybe have some abdominal symptoms, maybe have some weird rash. I think that would make me feel better about it. Yeah, but you're right. There are a large majority of patients who never had symptoms, never even knew they had COVID. But so this is the problem. In the beginning, any evidence of COVID was good enough for us. But now with Omicron, with a lot of people, this is with you know, the Omicron variant and us thinking that this is now endemic, many people are going to show up with the antibody, and it's going to be harder on us to try to figure out if this is MIS-C or not. And I'm going to depend more on having to go back and ask, were you sick? And then having to go back and say, okay, how much clinical features do they have? And that's why I kept showing you pictures of the rash. And they're talking about abdominal pain and neurologic symptoms, because those are very real features, and when you talk to people, they're there. You just have to kind of tease out those things. And then the lab abnormalities, it's just kind of, you know, lymphopenia seems kind of non-specific, but when you have lymphopenia and hyponatremia and hyperferritinemia, you're like, you know, it's looking more and more like MIS-C.
Yeah, and I, as you were talking, I was looking at your slide here, and I can see that this is like a very nice summary that sort of addresses my question as well. So, anybody else have any questions for Dr. Hong? Okay, well, thank you again, Dr. Hong, for your participation. For everyone else, it's 10:15. We're going to take a 15-minute break. We will resume at 10:30 with the virtual simulation. So feel free to remain online or log off and log back in if you will. At 10:30, we will divide you up into two groups, again, based on your hospital affiliation for the virtual sim. So if maybe you could come back a minute or two early, that might be helpful so we can get started on time. So I'll see you again at 10:30.